Welcome to our next Meet the Expert session on pelvic floor ultrasound. I'd like to introduce Dr. Ali Youssef. He's a consultant in obstetrics and prenatal medicine at Bologna University and is one of the leading authors in the field of ultrasound in labor and pelvic floor ultrasound. He is the social media editor in the Journal of Obstetrics and Gynecology at ISWOG and a member of ISWOG Basic Training Task Force. So welcome and thank you.
Hello, good afternoon, and thank you for being here. And it's finally an opportunity to meet in presence again. And I'll be talking about pelvic floor ultrasound. Okay, as Fiona has thankfully introduced me, I am an obstetrician. So obstetrics is what I do every day, and ultrasound, mainly in high-risk pregnancies, 3D ultrasound. And it was, so this is from a 3D point of view, what we like to see every day. Okay? So I have a passion for 3D. And fortunately, over the past 10 years, we have seen really impressive improvement in the quality of images, the ease with which we acquire images, etc. And it was clear to me that we can do more with 3D ultrasound, okay, to improve women's health. 3D is nice. Okay? It's very rarely helps us to diagnose in obstetrics. But regarding the pelvic floor, it's an incredibly useful and unique tool to help us see what we cannot see otherwise. Okay? As I anticipated, I'm an obstetrician, and for most of obstetricians, once you have the head coming out, most probably everything has gone fine, unless you have a shoulder dystocia or a postpartum hemorrhage. Your problems are already gone. But for many women, this is only the beginning, okay, of many problems for many years in her life, and unfortunately, almost always unexpected. Okay? Women do not know before delivery what risk they do have from a pelvic floor point of view. Okay? Just to illustrate the extent of the problem and the impact, this is an extremely interesting study produced by Professor Deet's group with Codwell Hall as the first author, and they try to answer an eternal question: what do women want? Okay? And they try to simplify it, and they hypothesize that women, at least in pregnancy, do want an atraumatic delivery. And they try to define what is an atraumatic delivery. And their hypothesis is that women do not want an operative delivery, that women do not want to have an anal sphincter injury during delivery, and they do not want to have a residual damage of their pelvic floor confirmed by ultrasound after delivery. Yeah? And in the second model, they included also microtrauma. Microtrauma is an over-distensibility of the levator hiatus, so it's a loss of tone, of muscle tone of the pelvic floor. And according to their data, in their population, they have found that only 40%, according to the first model, would obtain what they want from the delivery. And according to the second model, only 1 every 3 women will get what they want. Okay? This means that only today, in the first day of our Congress, about more than 170,000 women will not get what they want. Okay? We know that women in the immediate, in the labor ward, we can identify many costs that women do pay for having a vaginal delivery. So we know how to identify and the classification of vaginoperineal lacerations. So we have the first degree, the second degree, the third degree if we have the involvement of the anal sphincter, and then we have a fourth degree if we have also an involvement of the anal epithelium. Yeah? And we can identify the damage of some of the muscles in the perineal and pelvic floor muscles. So we can see the superficial perineal muscles, the bulbus spongiosum, and the superficial transversa perinealis, the perineal body. And we can also, with more attention, we can identify and suture the deep perineal muscles, so especially the perinealis the transverse perineal, deep transverse perineal muscles. But we have a deeper and higher muscle that it's almost impossible to identify in the labor ward, which is the pelvic diaphragm or the levator hiatal muscle, or the called the puborectalis muscle, which is the most central and biggest part of the levator hiatus, of the levator ani muscle. Okay? The levator ani muscle is much higher, much lateral, and the most central part, the green part, is the puborectalis muscle, and it undergoes incredible and exceptional stretching during vaginal delivery. Okay? So, and it forms a sheet penetrated by the urethra, the vagina, and the rectum. Okay? So this is the levator ani muscle seen laterally, okay? And it's penetrated by the pelvic organs, and it forms the largest hernial port in the human body. In labor, it gets overstretched on average about 300%, so 3 times its length. And we know from physiology studies that most striated muscles, if they get stretched over 30 to 40% their length, they have a high risk of having a permanent damage. So it's already miraculous that many women after vaginal delivery do not have a permanent damage of the levator ani muscle. And how does the damage occur? Well, the most common damage of the levator ani muscle is a detachment of the levator muscle, which in its insertion in the pubic rami, what is called the levator ani muscle avulsion. Okay? This is the most common injury of the levator ani muscle. Okay? So we can see on our left hand side an injured muscle, and on the right hand side an intact muscle. Okay? So so here that is a damage. So sorry. Okay, so the avulsion and intact levator muscle. So what are the consequences of having a damage of the levator ani muscle? I will talk about the clinical relevance of the damage of the pelvic floor. Why is 3D and 4D useful and not only 2D? And we'll try to touch on some technical aspects, and I would be happy to go into deeper explanation if you're interested. Okay, so first of all, the levator ani avulsion has an incidence of about 20%. So 1 every 5 women in their first vaginal delivery will have a damage of their levator ani muscle. We know many risk factors, but unfortunately, we do not have a clinically reliable and useful predictive model to counsel women before delivery, which women will have and which will not have an levator ani avulsion. So the increased maternal age, the use of forceps is one of the most important risk factors. It increased between 7 and 10 times the probability of having a levator ani avulsion. Women with a prolonged second stage have a higher risk of having a levator ani avulsion. Women with a small hiatal area at Valsalva, so women who are not able to relax their pelvic floor, are at high risk of having elevated anavulsion. Some studies have demonstrated a protective effect from epidural analgesia, and then this was a study that we published 3 years ago on the fundal pressure in the second stage. How many of you work in a labor ward or worked in a labor ward where crystalline maneuver or fundal pressure has been applied or sometimes applied? Come on, okay, 1, 2, yeah, but 30% on average, yeah. So unfortunately, it's a practice that is often performed, and my personal experience talking with many colleagues from all over the globe, that it's almost always never written in the patient's file. So it's very difficult to identify the consequences of a hidden maneuver. We have conducted this prospective study in Bologna, where I work, women undergoing crystalline maneuver with women without crystalline maneuver in the second stage. We have seen women 6 to 12 months after vaginal delivery. We have performed the ultrasound, and we have seen that women who undergo crystalline maneuver have more than a doubled risk of having elevated anal avulsion in comparison with women who do not, to which we did not apply the crystalline maneuver. This does not mean that crystalline maneuver is a crime that should never be done, but it's definitely not routine practice. It is not without risks. So I think this should be borne in mind before deciding to do it in the second stage. So what are the consequences of having a damaged muscle? Well, a damaged muscle definitely tends to contract less than an intact muscle. But the most important clinical consequence is pelvic organ prolapse. So we know that women who have an avulsion have more than a doubled risk of developing pelvic organ prolapse. Women will have the more severe the defect, the higher the risk of having prolapse. And we know that women with bilateral avulsion have even more risk of developing prolapse in comparison with women who have a unilateral avulsion. And lastly, women who undergo surgery for pelvic organ prolapse have a much higher risk of recurrence if they have elevated anal avulsion. So how can we diagnose elevated anal avulsion? How many of you are urogynecologists? Are there any urogynecologists in the room? Yeah. Okay. So urogynecologists can diagnose clinically elevated anal avulsion. The accuracy is not very high, and it needs a very long learning curve. MRI is reliable, but it's expensive. It's not easy to assess the dynamic aspect with MRI, and it is performed by a radiologist. Whereas ultrasound machine, we have it in our almost all outpatient clinics. Okay, so how do we do it? So the transperineal ultrasound, we use the convex transducer. We cover it by an abundant quantity of gel, and then we cover it again with a glove. And then if these are the first time that you perform a pelvic floor or transperineal ultrasound, you have to check that the upper part of the transducer corresponds to the leftmost part of the screen. Otherwise, you will have all the image inverted. And to illustrate what are the structures that you are expected to see, you just have to know the anatomy. So you just imagine the anatomy in the mid-sagittal view. So from left to right, you have the symphysis pubis, the urethra with the bladder, you have the vagina, you have the anorectum, and then you have the pubirectalis muscle. And then you just invert the image, and this is exactly what we see on ultrasound. So if you check the ultrasound image from left to right, you see the symphysis pubis, you see the urethra with the bladder, you see the vagina, and then you see the anorectum, and behind the anorectum you have the pubirectalis muscle, which forms the anorectal angle. So this is the anus, and this is the rectum. So this is the anorectal angle, and this is the pubirectalis muscle. Yeah. It's if you do ultrasound, you have a convex transducer, you can do pelvic floor ultrasound. Okay, you just prepare the transducer and just put it on the mid-sagittal view and try to get this image, the mid-sagittal view of the pelvic floor. And by simply doing that, you can not only see the pelvic floor, but you can help women, okay, whether to contract the pelvic floor. We know that pelvic floor exercises are useful and they can improve pelvic floor function, can improve urinary incontinence. And so with ultrasound, you can use it to do a visual feedback. So you just explain to the woman that this is your pelvic floor, this white part on the right-hand side is the muscle. If you contract it well, it will move to the left, okay? And you just let the woman try to contract. Many women will be able, without any further explanation, be able to contract well their pelvic floor. But we know that women, if you do not check, whether clinically, whether by ultrasound, that they properly contract their pelvic floor, sometimes they spend years, okay, thinking that they're doing the right thing, and sometimes they're moving their legs, their thighs, sometimes they're even pushing instead of contracting. And by ultrasound, it's immediate to know whether the woman can contract or not. And it can be used to help women to understand better their pelvic floor. Whereas some women are not able to relax their pelvic floor. So if a woman pushes, so she takes a deep breath, she keeps the breath inside and tries to push, and she pushes appropriately, she should be able to relax the pelvic floor. What should happen is the contrary. Instead to moving to the left, the muscle should move to the right. So this is on the right-hand side is a proper Valsalva. You see the bladder going up towards the transducer, and the muscle is moving to the right. Okay, so definitely teaching women how to contract is more important than the relaxation. Relaxation can be useful in very specific context, which is I would not, for the sake of time, maybe later we can talk about it if you want. So 2D ultrasound is immediate, easy, and you can see the pelvic floor. So why use the 3 and 4D ultrasound? Because if you'd like to see the whole structure of the levator ani muscle, you cannot see it in the sagittal views. Okay? It's a parallel plane, so it's impossible to see by 2D ultrasound. In addition, it's a thick plane, where a 2D ultrasound take just single planes. You need to construct a thickness of the muscle. And lastly, it's a curved muscle, especially under Valsalva. The levator hiatus is not a straight plane, it's a little bit curved. So 3D ultrasound is absolutely necessary to assess the pelvic floor. So how to acquire, okay? If you do 3D ultrasound, how many of you do 3D ultrasound? Okay, great. Okay. So you just place the transducer on the mid-sagittal view, okay, and activate the 4D, open the angle to the maximum, okay, and acquire, okay. So this is the acquisition. So you have to use the maximum angle, the high frequency, and the high quality. Yeah. And your aim, whereas, for example, if you take a 3D of the fetal face, you need to do a surface rendering in including in the box or in the region of interest the part of the fetal profile. For the pelvic floor, this is the plane that you need to include. Okay, so it's the lowermost part of the levator hiatus, called also the plane of minimal hiatal dimensions, and it runs from the lowermost part of the symphysis pubis. So it's the rightmost part on the image, okay, to the anorectal angle, so the most prominent part of the levator ani muscle. So this is the plane that you want to include in order to reconstruct the levator ani muscle. If you include this plane with a maximum thickness of 2 centimeters and a minimum thickness of 1 centimeter, so the thickness of your region of interest, whether you use the render technique or the OmniView VCI technique, should be between 1 and 2 centimeters. I think that 1 centimeter is more than enough. This is what you'll get. Okay, so you have the pubic rami, you have a 3D reconstruction of the pelvic floor, the urethra, the vagina, the rectum, and this traced area is the area included inside the levator ani muscle, which is called the levator hiatal, the levator hiatus or the levator hiatal area. Once you get the volume, whether 3D, so it's static, or better 4D, so you have many 3D images, and in the dynamic aspect, you should do 2 assessments. So start the acquisition and then ask the patient to contract, okay, and save it, and then start at rest and ask the patient to push to the maximum, and this is the maximum Valsalva. We know that 3D ultrasound machines gives you immediately these 3 images: the multiplanar plane, the plane A, B, and C. The plane A is always the plane of acquisition, so in this case is the mid-sagittal view. The plane B is the plane that you could have obtained simply by rotating the probe by 90 degrees, so it's in this case the coronal view. But our plane of interest is the plane C, okay? So it's the pink plane, okay? And it's the plane parallel to the transducer. This is where the levator ani muscle lies. Okay? So in our unit, we are fond of OmniView. So it's really extremely simple. You just draw a line between the symphysis pubis and the anorectal angle, and you apply the VCI. It's just immediate, okay? And you don't need to do any rotations, etc. And you can apply the linear reconstruction with VCI, so OmniView the VCI, in real time. So you activate the 4D, trace the line, apply the VCI 1 centimeters, and ask the wound to contract. It's that simple. Yeah? And this is what you get in real time. Yeah? And applying the same technique, you trace the line and ask the woman to push, and you see how a proper Valsalva maneuver is associated with an increase in the dimension of the levator hiatus. You have to note that sometimes, since the relationship between the symphysis pubis and the anorectal angle can change from the beginning of the acquisition till the end, sometimes you need to retrace if you want to see the muscle at rest, you trace the image and then go to the end of the clip and then recheck that the line is still including the symphysis pubis and the anorectal angle. Okay, so you see on the left-hand side, you see that the puborectalis muscle is moving up. Okay, so although the here is the levator ani is still seen well, you should have moved the line a little bit up. Sometimes this adjustment is not necessary, but just you keep an eye that every image that you have, the line is well aligned. So the first damage that we talked about is the macrotrauma or the levator ani avulsion, the detachment of the muscle from its pubic rami. The other damage that a muscle can have due to labor is the microtrauma or an overdistension of the muscle. So to assess the integrity of the levator ani muscle, ideally you should apply the multi-slice technique. It's called the TUI, tomographic ultrasound imaging. You have to use a 2.5 millimeter between one slice and the other, and with the central plane, the plane of minimal hiatal dimensions, and you should assess the central 3 images, and to check that you have done a good alignment. On the first image on the left, you should see some space between the pubic rami. On the central image, you should see this space extremely closing but not closed. And on the last image on the right-hand side, this you shouldn't see no space between the pubic rami. So this is to check that you have done a good reconstruction of the levator ani muscle. And this is where you should comment on the integrity of the levator ani muscle. So here we have the levator ani muscle perfectly intact bilaterally, whereas here, for example, we can see clearly that the right levator ani muscle has been detached from its insertion. Okay, so this is a right levator ani avulsion. And this is a micro trauma. You see that you cannot really see a clear defect, but you ask the patient to push, and then you have what's called ballooning. So the muscle is extremely over distended, and it has a definition. So the definition of levator ani muscle ballooning is a levator hiatal area more than 25 centimeters square under maximum valsalva. Okay, so this is the part of the levator ani muscle. For the sake of time, I have to talk about the anal sphincter injury, but it's difficult to have a whole lecture on it. So definitely, anal sphincter injuries is one of the nightmares of the obstetrician, especially from a medico-legal point of view. We know that in most units there is no proper training of the midwives to examine the sphincter. There are improper training for all the staff to repair the anal sphincter. So there are a lot of things to do, and ultrasound can identify the anal sphincter injuries, not in the labor ward yet, okay, but at least after 3 to 6 months, when the patient come for an ultrasound, we can examine the levator, the anal sphincter injuries. The gold standard still used by proctologists are the endoanal 360 degrees transducer, and we see here the anechogenic rim circle is the internal sphincter, and then we have the hyperechogenic rim outside is the external anal sphincter. So this is still considered the gold standard, but transperineal ultrasound, again by a convex transducer, volumetric transducer, by placing it not in the mid-sagittal view, but perpendicular to the anal sphincter, and by acquiring a 3D volume, can reconstruct very reliably the anal sphincter. And there are many studies that demonstrated that the transperineal ultrasound can produce results that are comparable with the endoanal ultrasound. Okay? Of course, it's not shared by all proctologists, and I think that it's a field that we still have a lot to do, but definitely it opens our eyes by using a tool that we have in our everyday life to structures that we are extremely interested to examine. So the same, by applying the same technique, the same concept, the anechogenic rim is the internal sphincter. The surrounding hyperechogenic rim is the external anal sphincter. This image is a two-dimensional one, but to standardize the examination of the anal sphincter, you should apply the 3D ultrasound by doing, again, the multi-slice technique. And these are the signs that you should look for. You see on the leftmost image, you see that there is a tone, a high tone in the anal sphincter, creating this star sign inside the anal canal. And this an damaged sphincter in which there is a loss of the star sign. In this case, we have you see that the black ring, the internal anal sphincter, is intact, whereas the external anal sphincter at 12 o'clock there is a missing part. So this is an improperly repaired or non-identified external anal sphincter injury. In that case, we have an intact external anal sphincter. So the external anal sphincter has been properly sutured, whereas we have a missing part of the internal inner sphincter, so what's called the half moon sign. And I think that one of the most important uses of this technique is the audit. Okay, so if you see the patient that you suture, okay, with an external inner sphincter injuries, I think that you can use it to do an audit, to identify proper repair, to try to correct improper repairs, and it's really extremely interesting. Unfortunately, my ambition, our ambition, is to have the ultrasound useful in the labor ward to help us diagnose in the labor ward intrapartum anal sphincter injuries, and unfortunately we have not reached that objective yet. So okay, so to sum up, so pregnancy and delivery definitely they are the most important risk factor for pelvic floor dysfunction. Okay? Ultrasound is a reliable and objective tool to assess the pelvic floor structures. We still have space to improve our prediction models and our preventive interventions to help women to have less pelvic floor dysfunction and problems later in life. But it's like all fields in medicine, it starts with an accurate, reliable diagnostic tool, which we finally have, okay? And this is on which we are constructing our primary, secondary, and tertiary management plans. Thank you for attention, okay? And I would be happy if you have any questions, even technical.
Are you making a good case for elective C-section?
Absolutely not. Is that a question? Is that a question or an affirmation?
No, no, I know you're not.
No. Well, I'm an obstetrician, so I would not. But I think that we have to treat women as adults. Okay, so if I would be pregnant someday, okay, and by giving birth, I'm giving birth in a hospital that have a 4% risk of having an anal sphincter injury, and I'm giving my first delivery at 45 years, so I have a almost 40-50% risk of having levator ani damage, and I have a very high risk of having prolapse and incontinence later in life. I just want to know it, okay? And I may well decide to give vaginal birth, okay? But I think that hiding information because we are worried that maybe women will ask for cesarean section, I think it's an improper way to treat women from birth.
So are we informing them that this may happen? Do you tell your patients there's a 30% chance of? But you tell
absolutely not. Absolutely not. This is nobody does. Nobody does. But because I cannot. But this is what I hope it will happen, that women will be given some kind of leaflets about the benefits of vaginal delivery, and the risks, the benefits and risk of cesarean section, and that the natural way to give birth is the vaginal delivery. Okay, but of course I would not talk about risks that have a probability of 1/10,000. Okay, so I will not tell them that you have a risk of mortality. I will not talk about maternal mortality. Okay, but I think that 3-4%, 20%, these are substantial figures. I think that it's improper not just to ignore it. I know that it's very provocative and controversial, but we often have a very paternalistic way of dealing with women, and it's definitely improving and changing, and women are much more aware of their what is pelvic floor, okay? What does incontinence mean? That incontinence is not normal, and we have been silencing women whether directly and indirectly for a long time by saying that, well, it's normal, you have given birth, you are incontinent, it's not a big deal, but most women do not accept that anymore.